Good morning, everyone. We would like to welcome you in the third day of our Oman Health Conference. Today, we have experts from USA to discuss new updates regarding cardiology and diabetes. Regretfully, our first presenter couldn't make it to an emergency. We will proceed to our next presentation. Our next speaker is from international medical consultant to several countries for wound and burn management. He's an international medical director and chief medical officer, worldwide wound care LLC at Miami, Florida. Let us welcome Dr. Larry Barata.
Good to be here. This morning I'm going to have us focus on the relationship between diabetes and wound care. And I'd like to start off with the first slide, a brief overview, diabetes mellitus. I always like to find out the etymologic derivation of a word, because if we know the meaning, we'll be able to understand more deeply what's happening in the patient. So let's talk about diabetes. We see the word diabetes from the Greek means to siphon off. Another way to put it is to pass through. So to siphon off, what's happening is that the glucose is being run through the nephron, which is the functional unit of the kidney, and right into the urine, which we call glycosuria. So that's what the word diabetes means, is to siphon off. The word mellitus means sweet tasting, which makes sense. Because if we look at the constitution of the urine, we're going to see a high level of glucose. So that word derivation is very relevant to the disease process. We see, however, diabetes is a metabolic deficiency affecting three major metabolic pathways: fat, protein, and carbohydrate. And these pathways will affect many organ systems. We have diabetic cardiomyopathy for the heart, diabetic retinopathy for the eyes. We have diabetic nephropathy, very good for the kidneys, and here's the unique thing, which I'm going to talk a little more about later, why diabetic peripheral neuropathy is so important, and what's the pathophysiology. Because in order for the glucose to get into the cell, and we know glucose is an energy source, it needs insulin. Insulin is the key to the lock to open the cell door so glucose could get in to be metabolized. In type 1 diabetes, it's not possible. Type 2, we see that there's an insulin resistance factor here because the receptors on the cell are not susceptible to the effects of the insulin to allow the glucose to enter the cell. So that's diabetes mellitus. What about statistically? Statistically, global issue, I know diabetes is a pandemic problem. Okay, so let's look here. We see that 1 in 10 suffers from diabetes. The prevalence worldwide is 10%. I do a lot of consulting throughout the Middle East. My primary country of responsibility is Saudi Arabia. In Saudi Arabia, the diabetic incidence is about 35% of the population. That's significant. In the United States, it's about 8 to 9%. Because we know one of the predisposing factors to the development of diabetes is obesity. And Americans are now into that category of being obese. We see that 12% of the world's populations are considered obese, okay, 1.5 billion people. Americans, as I just mentioned, have highest levels, 26%, and we see that women are more likely to be obese than men. So you have all of these lifestyle predisposing factors that will lead to the development of diabetes. So if we modify our lifestyle, can we potentially prevent diabetes? Yes, we can. Absolutely we can. Okay, so I've taken the metabolic problem of diabetes and now let me link it to a wound. That's the focus of our conversation. We see the primary cause diabetes, now we see the onset of a wound. My colleague, Dr. Four, has a wonderful non-clinical definition of a wound. A wound is a battlefield where the skin is losing the fight. Think about that for a while. It makes so much sense. If we know that the skin is the largest organ in the body, also known as the integumentary system, we know we must preserve the integrity of the skin to be able to preserve the integrity of the organs it protects. Let's go back to the Greek for a second. The word integument means rind. So if you look at an orange, the rind of the orange is the integument of that fruit. We see that the integumentary system has a wonderful array of functions, but we must make sure there is no breach or deficit or void. Because if there is this potential portal of entry, what happens? We have an increased morbidity potential and in some cases, mortality. Christopher Reeve, Superman. We all remember that movie, Superman? He had that equine accident. He became a quadriplegic. What did he die from? He died from an infected bed sore. So we see that he acquired a decubitus, an infected bed sore, and what happened? That was a portal of entry for infection. Tragic. So it is incumbent upon us as clinicians to make sure we heal this wound quickly. And we know in diabetes, these patients have these wounds chronically. I've had patients who have wounds for 20 years. They come to me and I say, really, 20 years? And thankfully, we're able to turn the tide and heal them very quickly. And I'm going to talk to you about the best primary solution for wound healing. So this is a great slide because this slide brings it back home and allows us to really focus on what are the main issues. Okay, let's look at the 3 phases of wound healing. We have coagulation and inflammation. This is your phase 1. Inflammation is the body's response to injury. Makes sense. And if the body has sustained injury, we know there's going to be bleeding. So therefore, we have coagulation, we have platelet aggregation, we have the thrombocytes coming in, and we're able to control the bleeding because we do not want to exsanguinate. We want to preserve the hemodynamic status. So that's phase 1. Phase 2 is migration and proliferation, where we have the fibroblasts, which are the main cells for healing, to be able to establish a biologic scaffolding in the wound bed. Because if we have the fibroblasts, we're going to encourage granulation tissue development. That's a key player here in wound healing. And then we have remodeling, which makes sure that the tissue comes back, actually the tensile strength of remodeling is never back to 100%. The max is about 80%. So we have 3 phases. But here's the thing I want to tell you. These phases don't start and stop, they overlap. As we have the inflammatory phase, we can also have the proliferative and the migratory phase. So here you have the 3 phases of wound healing. What about in diabetes? What happens here in diabetes? We see very clearly that phase 1, we have a sustained inflammatory response. The body doesn't correct itself because remember, the primary pathology in diabetes is a major metabolic deficit. Major metabolic deficit.